Hello, everybody. I continue my project with interesting clinical cases. This specific case was interesting for me because of its rare anatomical configuration. I think if I will put this clinical picture in social media and will ask what the numbers of the tooth, many dentists will answer that it's some type of low molar, but it wasn't low molar. This is why I want to show you this case. It was an upper molar after the first aid. The treatment was started because of necrotic pulp and symptomatic apical peritonitis. During examination, about 1 month after the first aid, percussion negative, palpation negative, no pockets, no sinus tract temporary filling, and nothing in periapics, maybe some widening of PDL, but I'm not sure. And my final diagnosis was previously initiated treatment and normal periapics. The reason for referral was the problem with the mouth opening, very limited mouth opening, about 22, 23 millimeter. And this why the patient was referred to my clinic. And you see indeed a very complex anatomy, unusual one for the upper molar. To do it easier for you, I want to show you where were the distal buccal and mesobuccal canals. But what we have now in palatal part, we have three possibilities. One of them is a very rare one when we have two different palatal canal, P1 and P2, and we know in the literature their prevalence is very low. In some research that I finished now in Israel and Israel population at about 0.02% of the population, and we know it's a rare one. Second possible possibility, it's very interesting possibility of palatal canal and mesopalatal canal. This possibility was firstly described in literature by Professor Marco Versiani and last year. And of course, we have a possibility that we have here palatal and mesobuccal second canal, that it's a really very rare configuration, but also is possible. The question, if I have no idea what I have, what type of canal I have, if it now the situations that I need refer patient to CBCT. In my opinion, no. Please remember the principles of ALARA, as low as reasonably achievable. What it will give to me and to patient for the treatment? Nothing. If I find the canal, it's not so important now to understand what I have. And also I can continue my treatment, and maybe during that working length determination, the X-ray for working length determination, I will understand what I have in this case. And I continued my work. And finally, you can see the working class determination X-ray. By the way, pay attention that I used night-eye control memory vary instrument. Why? Because of limited mouth opening, I pre-curve them to put inside during the working length determination. You see the palatal canal, and here you see this second palatal canal that now we understand it's MB2. Okay, good. I have found the canal. I know what the canal I have, and I continue my work. In this specific case, as I explained you earlier, I use night eye instrument done from control memory wire, some specific system named MS, that it's control memory wire instrument, multi-file system with taper no more than 0.4. And they use in this specific case because it was non-vital teeth from the beginning, HEDP, hyaluronic acid, mixed with anal cells, the idea of continuous chelation to lower smear layer and to low debris in the root canal system. And in the end, I use as an additional system, as a final system, as irrigation system, I use SAF, self-adjustable file. And finally, I use my combination system of lateral compaction, vertical compaction, and hydraulical condensation to fill it with epoxy sealer named BGM with micromolecule. And this is the final result. And again, I like to see how our canal uneven. You see some, narrow part and palatal canal, wide part, narrow part. Again, it's very nice to see this anatomy. And in the many of cases of mine, I like to do and 2 or 3 in some of the cases, different angle X-ray to see the final result. And I did the same in this specific case. And now, please pay attention. What interesting thing I can see now. I can see now some very nice detail here. Okay, you can see some additional canal, maybe some lateral canal. Okay, maybe some dividing for MB2 and MB3. I have no idea. I see, I see some interesting anatomy in middle apical part. And it's understandable for us that my instrument wasn't inside. All that we have here, all this sealer inside, does because of high quality irrigation. And I think, of course, it's my speculation, but I think that the using of HEDP and NOCL in this specific case prevent accumulation of debris and prevent accumulation of smear layer in this place, okay, in this dividing of main canal to additional part, and these give opportunity to NOCL to work very well and to dissolve the organic tissue, and finally give opportunity to the sealer go inside. Just for me support the quality of irrigation with continuous chelation technique when NOCL combined with HDP. I hope this case was interesting for you. If you have a question, please write them and I will answer. Have a nice day.